Okay, there we go. All right, so Amir, thank you very much, and we hope that you won't be the only attendee, but we are recording this, and I've got to thank Dr. Catie Price for taking time out of a busy schedule for being here in the morning in the United States, and we're going to talk today about endocrine emergencies, and I think specifically, I guess, endocrine consults in the intensive care unit, right?
Yes, yeah, more so a top-down
Excellent.
approach. Yeah.
Okay, very good.
Um,
So, oh yeah, I'm going to give you your 1 minute biography.
okay,
I'm going to
that's okay.
extol your virtues now. So, so Dr. Price is an assistant professor in the Department of Medicine and in the section on diabetes, endocrinology, and metabolism at Wake Forest University School of Medicine. She received her medical degree from Mercer University School of Medicine, which I believe is in Georgia, right?
Correct.
And then she completed her internal medicine residency and was chief resident as well as a fellow in endocrinology at Wake Forest in Winston-Salem, North Carolina, now rebranded, I guess, as Atrium Health Wake Forest Baptist. Her research is focused on the use of diabetes technology, including continuous glucose monitoring devices, as well as insulin pumps in optimizing care for patients living with diabetes. She's currently the medical director for inpatient glycemic management at Atrium Health Wake Forest Medical Center. She's actively involved in teaching medical students, residents, and fellows. And she's also engaged in supporting the inaugural diabetology fellowship at Wake, which I guess just started this current academic year, right? Just finishing up. Or
Yes.
actually, maybe we're already into the next year. So, but it's still hot off the press. So anyway, without further ado, I'm going to hand the microphone over to Catie, and she's going to talk to Amir and me, and anybody else that shows up about endocrine emergencies. So, Catie, thank you very much.
Yes, thank you so much for having me. So this is a talk that really started from our own critical care department at Wake asking, we really need more education on all of these consults when we reach out to the endocrine team. So I'm going to go through these. So we'll do a top-down approach. I don't have any disclosures, and we'll try to go through all of the endocrine emergencies in terms of what we should do for these events. So I'm going to start with the very top. So pituitary emergencies. So this is a patient who presented sudden onset headache, worst headache of his life he'd ever had. This was his MRI before coming into the hospital. So just a little bit of a rounded pituitary gland, but not anything really, super worrisome. On arrival, he's, throwing up. He has double vision, afebrile, hypotensive, and tachycardic. And his MRI on admission was actually very concerning for apoplexy, that he had bled into a pituitary lesion, and this is a life-threatening critical emergency that needs to get caught quickly. Ideally, an MRI. Or CT with contrast can also be utilized, but it's something that endocrine neurosurgery needs to get involved with, and if ophthalmology is available for visual field testing. But the critical thing to not miss is to go ahead and give this patient stress dose IV steroids, even before you can get any labs drawn. That can be a life-saving medication to start hydrocortisone 100 milligrams IV and then continue it at 50 milligrams every 6 to 8 hours. If this continues to progress, patients can become quite altered, hypotensive, and it's from that critical glucocorticoid deficiency. And then
So this
ongoing
is an
visual field.
Addisonian crisis, right?
Essentially, yes, but it's from that acute loss of ACTH production from the pituitary gland. Some of these require decompression, some don't. I'm not a neurosurgeon, so I will leave that call up to our neurosurgery colleagues. But certainly from an endocrine perspective, we need to support them with steroids. And then there's other hormones that we need to be worried about that they may be, suddenly deficient in, and that would be thyroid hormone. Now, this takes a little bit longer. The patient's not going to go into myxedema coma immediately. Thyroid hormone typically is in our body circulating for about 7 days at a time, but needs to get replaced. Ideally, we do that with oral and not necessarily having to do IV as long as the patient's safe to take that. And then monitoring also for arginine vasopressin deficiency. There's been a renaming of this in the some of the literature. It hasn't caught on everywhere. So prior naming was central diabetes insipidus, but then sometimes gets confused with diabetes mellitus on the words. And so we've been trying to change our naming for that so it's more specific to what the deficiency is. So these folks with pituitary apoplexy also need close monitoring of their ins and outs for how much urine they're making, and if it's becoming rapidly dilute, if they're not able to access drinking to thirst, they can very, very quickly develop hypernatremia. And so, following their BMP, we replace that diuretic or antidiuretic hormone with DDABP, either IV or you can use nasal spray if they have not required, a transphenoidal decompression surgery. IV or sub-Q are typically what we use for that.
And how much fluids are you giving them? I assume you're giving them
Yeah,
pretty
so
aggressive
normally
fluid
we're having to
resuscitation.
replace they're dumping just free water. And so they're needing more free water back. If they can drink to thirst, great, but for a lot of these folks they cannot. So it's good if we can, have some way of giving them either, like D5 half normal, some type of a fluid resuscitation as well, in addition to replacing the hormone
Right. But
deficiency.
we're not, but we're watching their osmolarity and we're not giving them normal saline, right? Because they're going to be
Correct.
hyperosmolar.
Yeah, so normally we're having to give them basically just back the free water that they have lost,
Mm.
is the best thing to do, and then also replace their DDAVP. We usually don't schedule dosing for that. We'll follow their urine output. Once they have 2 hours, or at least an hour of more than 300 cc's of urine output, that's when we would consider redosing their desmopressin.
Right. And how often
Yeah.
you checking electrolytes?
So usually at least if they're in the ICU, like every 4 hours, is more standard for these folks in the critical care. On the floor, that's hard to do. It's probably closer to every 8 hours or at least twice a day at a bare minimum, if they're stable to be on the floor.
Right.
Yeah. Other endocrine emergencies, we're going to try to go from, head down or thyroid related. And this is probably our most common consult is, we think we have myxedema coma or the opposite end of the spectrum. We think we have thyroid storm. And it is a spectrum of disorders. So we'll start with hyperthyroidism. So this is a patient presenting with thyrotoxicosis. They're at the emergency department, fatigue, weight loss, chest pain, really cannot sit still. They're just like pacing around the room. They're febrile, tachycardic, and then we get labs, which shows complete suppression of TSH. Very elevated free levels for both T4 and T3. And then adding on, especially if you note, the eye symptoms in this patient, they're having that proptosis. If you're doing a lid lag assessment, they'll have lid lag, this stare type of a feature from inability to really close their eyelids well because of the proptosis. And so checking for antibodies to screen for Graves' disease can be helpful. So we usually get the thyrotropin receptor antibody for these folks. And then recognizing, when and if it's thyroid storm, these folks will progress to very severe symptoms, usually from, monitoring their cardiac output, their tachycardia. They can become quite delirious. There's typically some precipitating event that has pushed them over the edge into storm, whether that's, infection, a surgery, trauma. They got iodine for something. Whether it was radioactive iodine or, a heart cath or CT scan. Asking about family history, personal history can be helpful, or if they've ever required antithyroidal agents in the past, or if they have, one of these incidental findings that tip them over the edge. Um, for the exam, I mean, we've kind of talked through this with, how the patient presented in terms of the eye findings, but then, also looking to see, they have a goiter. You can often appreciate a bruit over the thyroid gland from how hypervascular it is. These folks can also get high output heart failure from how tachycardic they have been for a prolonged period of time, hypercalcemic, liver function abnormalities. And so there is a helpful tool, which I'm not sure if you all use where you're located, called the Birch-Wartofsky scoring system. But this is a tool that we use in our emergency department and then the critical care department also, but primarily in the ER when we're triaging, does this patient really, sick enough to need an ICU bed, or can they go to floor level of care? So this is something you can, you plug in their temperature, if they're having agitation, if they're having GI issues, how tachycardic are they? Are they having signs of congestive heart failure, arrhythmias? Was there a precipitating event? And it will actually give you a score, and some guidelines for, how to best manage the patient, which can be very helpful. Particularly if endocrine is not available. Some of our outlying hospitals don't have endocrine consult available, and so they utilize this tool a good bit. Um, you can also do Doppler or ultrasound of the thyroid gland. This is called thyroid inferno that we see from this AV shunting that will occur due to the increased vascularity throughout the gland. We typically only see this in Graves' disease from that antithyroidal, the thyroid antibody. And then to treat, so beta blockade is very important. They're at high risk for these tachyarrhythmias, and so starting on a beta blocker promptly, we typically use propranolol here, 80 milligrams every 6 to 8 hours. If blood pressure is very tenuous, IV esmolol is a go-to in the ICU. Antithyroidal agent depends on the attending who's on call. I tend to use methimazole, 20 milligrams, 3 to 4 times a day, depending on how hyperthyroid they are for storm. Steroids can help block the conversion from T4 to T3. Um, the high dose iodine, in terms of giving Lugol's drops to suppress through the Wolff-Chaikoff effect, can be used, but then there's this Jod-Basedow escape mechanism, around 10 days or so. So I typically don't use that unless I know we're going to pursue definitive therapy with thyroidectomy for patients, but that can be used. Cholestyramine can be given. It's a couple of times a day, but it binds the intra luminal thyroid hormone in the gut, and then they'll actually poop out some of their thyroid hormone in excess. So that can be used. Plasmapheresis is rare, but we'll talk about that on the next slide. And then, supportive care, treating what tipped them over the edge. I do have to call out Dr. Ober. He's a former attending who sadly passed last year, but he had the best tip for if you have to use Lugol's to mix it with orange juice or a juice that you have available. That's one of the only ways we can get folks to tolerate that. So we get asked sometimes, when would you do plasmapheresis? It's not very common that we have to do this, but it does work well if we're having a patient who has very poor response to the standard of care treatment to lower their thyroid hormone level. If they're having a granulocytosis from, methimazole or PTU and we can't safely administer those. Has also been used for some other purposes, and it's rare. This is a retrospective case review over, just about 10 years. They only had 11 patients. So it's not common, but if you have to do surgery rapidly, so this patient had a hip fracture and they needed to get rapid control of their hyperthyroidism in order to safely do anesthesia. So that's another instance that you may need to plasmapherese someone. On the opposite spectrum of hyperthyroidism, we have hypothyroidism with mixed edema coma. And these folks, they're not mentating well. They're hypothermic, they're bradycardic. Again, family history, personal history can be very important, especially if they've had any history of thyroid surgery in the past. But also thinking of central hypothyroidism in terms of if they've had, brain surgery, pituitary surgery, head trauma. Similar things that we would check, in terms of their vitals, their mental status, looking for abnormalities on their EKG. These folks are hyporeflexic, particularly with a delayed relaxation phase, and can also get hyponatremic, hypoglycemic. This was a case that was written up in NEJM I just thought the pictures were, so marked that this was the same person during the same admission for how they looked when they came in with mixed idiom coma to, what they looked like leaving from just needing thyroid hormone replacement. So
How
this
long?
patient,
How long?
yeah.
How long length of stay was this? Because this is a
Oh, good
dramatic
question. Yeah, it's
improvement.
very dramatic. I'd have to go back. This was published in 2015,
Amazing.
but I think it was less than a week. I mean, we usually see folks turn around
Really?
pretty rapidly, like in a couple of days, if that was truly what caused them to be in that myxedema coma. That being said, sometimes there's other offending agents or infections that have tipped them over the edge that take longer to recover from. Um, and
Right.
so
I mean,
this patient, yeah,
what is the soft tissue edema? What is the mechanism that
yeah. So they get this
responds or resolves apparently so
mhm.
quick?
They get this pitting, doughy edema from lack of thyroid hormone, which you've ever seen. It actually feels kind of like kneading dough. Um, but yeah, so it is related to their heart failure, or thought to be primarily related to that in the bradycardia. Like,
Mm.
the heart truly needs
Ah,
that
okay.
T4 to T3 conversion, or it's not going to function optimally at all. Um, Yeah, so cardinal features. So if they're altered, hypothermic, bradycardic, needing ventilatory support, and then looking not just based on labs, but what was the inciting event, and if you're really suspicious that they're in myxedema coma and you're planning on giving IV thyroid hormone, there's another medication you need to give first. So stress dose IV steroids need to be given first. Often we'll see patients, if it's particularly autoimmune, they may also have adrenal insufficiency. And so giving the levothyroxine first can actually incite an adrenal, Addisonian crisis. And so we give hydrocortisone first and then followed by the IV levothyroxine. There are some guidelines that say to use T3 IV. We don't actually typically use that here. Can induce arrhythmias just because of how arrhythmogenic it is to the heart. And then these folks also require significant care if they're in true myxedema coma. Okay. I'm going to go kind of quick through these because these are not as common, and I want to get to some of the other ones. But going top down, so parathyroid, severe hypercalcemia can occur. They'll have a shortened QT wave on their EKG if they're having a high enough calcium. This patient came in confused, delirious over 2 weeks duration, and with a acute kidney injury. So hypercalcemia, when is it emergency? When is it not? If it's less than 12, that's usually managed an outpatient, not an emergency. But if it's above 12 and they're having change in their mental status or arrhythmias, typically we would admit to the ICU or intermediate level of care, which is for us a step above the floor level, and then have that patient on telemetry and check their calciums frequently, and then working up, what was the etiology. So if it's severe, calcium high, PTH is high, then it's, odds are it's primary hyperparathyroidism. But for most folks coming into the hospital, I'd say it's more common that we see a non-PTH mediated reason. Cancer is a common one, although in my career in the last, since COVID times, I have seen a lot more vitamin A toxicity and hypervitaminosis D, I think from folks trying to either have preventative care with taking a lot of high dose vitamin D supplements for bone health or COVID, or taking multivitamins that contain a high amount of vitamin A for trying to prevent macular degeneration, of all things. We've had a number of consults that was the cause of their severe non-PTH mediated hypercalcemia. Treatment for either is kind of similar, other than, working up the underlying agent. So these folks need a lot of fluids, as long as their heart can take it. And then it's one of the rare times that we give, a diuretic in combination with the fluid to help the kidneys dump out the calcium in the urine. Calcitonin can also be used just for a couple of days. Can help in the acute setting, but wears off and doesn't have much effect after that. And then other considerations really depend on the driver of it. So some patients would actually benefit from parathyroidectomy inpatient if it's more of a parathyroid crisis with severe hypercalcemia from primary hyperparathyroidism. And then for the malignancy cases, working those up. Sometimes steroids are indicated if we're thinking it's, sarcoidosis or vitamin D toxicity. Addison's can also cause hypercalcemia. Hemodialysis may be required, if they have enough kidney impairment. And then bisphosphonate, if they have not had too much kidney impairment, can be helpful in lowering their calcium, but does take a couple of days to see the full effect of that. But fluids is one of our best friends for treating these. On the opposite spectrum, so we see severe hypocalcemia. This is more common in patients who have had neck surgeries with hypoparathyroidism, which can be permanent, or some cases it's temporary, and then the parathyroid glands will come back. Um, they'll usually present with this, perioral numbness or of the fingertips, toes. We'll notice that. Um, We'll also have Chvostek's sign, the fifth cranial nerve or Trousseau sign, which you can elicit when getting a blood pressure. They'll have this, spasming in their muscles from that. If it's low enough, so usually if, corrected calcium is in the 5 or 6 range, they really have, lost their storage of calcium. And so this is kind of our endocrine special that we do, at least at our institution, is 10 amps of calcium gluconate. Pharmacy will mix that in a liter of normal saline, and then we give that over 10 to 12 hours. We usually check a CMP halfway between and at the end of that infusion to see and make sure we're not overshooting. And then also starting them on an oral calcium replacement if they're, on any acid blocker or like PPI protonics, then calcium citrate's preferred for absorption. These folks need to be on telemetry, and then magnesium is also important. So you can actually see severe hypocalcemia from a severe magnesium deficiency. The times I've seen this, it's usually alcohol abuse where folks are just not having good PO intake of anything else and can get very severe hypomagnesemia, and that impairs the parathyroid hormone gland from actually releasing PTH and results in hypocalcemia. Okay. Um, Continuing to kind of move down in the body, we're going to go to adrenal next. So this was another NAJM presentation that I just thought was a marked picture to have. So panel A is a patient that was on admission, but 6 months prior, he looked markedly different. He came into the hospital with confusion, emesis, unintentional weight loss, had noted skin hyperpigmentation, hypotensive, tachycardic, hyponatremic with hyperkalemia. And so what's the best step? So giving him steroids in addition to, working up, what led to this in his baseline labs. He had presented with adrenal crisis due to lack of glucocorticoids and then sometimes mineralocorticoids if it's primary adrenal insufficiency. Patients will present very similar to how this gentleman did, plus minus the hyperpigmentation. So if it's primary, they will have that as well from that increased alpha melanocyte stimulating hormone as a byproduct of increased regulation of ACTH. It comes from POMC or pro-opiomelanocortin that breaks down into ACTH and alpha melanocyte stimulating hormones. That leads to the hyperpigmentation. And then fatigue, weight loss, salt cravings if it's primary. And I think this is a topic that's near and dear to my heart, but we're actually not very good at diagnosing it. If you look at, we had a cross-sectional study of, how long did it take before patients were diagnosed with adrenal insufficiency? For some folks, it takes quite a while. 20% of patients actually went 5 years. That's more so secondary adrenal insufficiency than primary, but only 15% were diagnosed correctly at the first visit. Most of this was due to how subjective the symptoms were. And the fact that, there's a lot of GI complaints, there's a lot of kind of depression, fatigue complaints. And so often folks are mislabeled with either a GI condition or a mental health disorder and not getting the workup or testing for adrenal insufficiency. This is another patient that we'll go over quickly. So this is a 47-year-old woman. She presented with refractory nausea, emesis, severe headaches, photophobia, unintentional weight loss that was pretty profound over 6 months. Had numerous episodes of seeking care with her PCP, hospitalizations. She was actually diagnosed on the 5th hospitalization with cryptococcal meningitis and treated with amphotericin B, and currently on diflucan suppressive therapy as an antifungal. And she comes in for her 6th hospitalization. These are her labs, which if I'm teaching our, residents and fellows here, we'll go through and I'll ask them to interpret. But I'm not sure if there's many folks on. So she has positive cryptococcal antigen, still, despite, getting amphotericin B, being on diflucan, positive fungal culture, and someone thought to check a cortisol because she had this weight loss, GI symptoms, fatigue, not doing well. And it was quite low, 4:30 a.m. of 0.5, 11:40 of 0.1. Aldosterone, which is another adrenal gland hormone, was undetectable. Renin was high and very high ACTH. Uh, the endocrinologist who was consulted also thought to do some other workup since autoimmune is more common in the US, while we see some infectious etiologies more common internationally. Her 21 hydroxylase antibody was negative. She was found to have bilateral enlargement of adrenal glands. And after pheochromocytoma was ruled out, actually underwent an FNA and was found to have cryptococcus. And so I share this case. Because this was actually my mom. So I wrote
Oh,
it up
wow.
once I was an attending, but she is very lucky to be alive today because an endocrinologist said, "Hey, y'all should check a cortisol." So I always encourage all the learners, if they ever have a hypotensive patient and they're not really sure what's driving it, or if there's something else going along, they're not responding to pressors, just check a cortisol. With the admission labs, that can be a life-saving thing. So I'll go back a little bit because I know I didn't go over the cutoffs for things in the slides earlier. But if you have a cortisol, really under 3 and any morning outpatient patient is concerning for adrenal insufficiency. But if you have someone who's critically ill in the hospital, our, consentropin stim test, we typically try to see a cortisol response up to like, 14, 15 is a good sign that their adrenal glands are functioning. If someone is sick as, I call it sick as stink in the ICU or critical care setting, it should be at least 15. If it's not, they already failed their stim test of coming into the
Mm.
hospital and would probably benefit from a workup. So just to raise those numbers. There's
So
a
this
lot of
was
different,
this was
yeah,
fungal sepsis
yes. So
leading
she had
to.
disseminated cryptococcal neoformans for meningitis.
Now,
Um,
that seems pretty rare from somebody who doesn't have some underlying immune
it is
issue, right?
rare, yeah. So if you ever want to look it up, you can
I
Google
see you published it.
adrenal insufficiency in my name. But it took about 2 decades for her to get diagnosed with common variable immunodeficiency. Because she was from
Wow.
a rural area of Georgia that did not have subspecialty care for the
Right.
most part.
Wow.
Yeah. So yeah, and she's still living today, but has primary adrenal insufficiency, lifelong, and actually lifelong suppressive therapy for the
Right.
cryptococcus.
But it shows you the importance of giving steroids, right, to a
Hmm.
patient who's in shock, who's not responding to fluids and pressors, right?
Correct. Yeah, it can be life-saving.
Mm.
Um, these folks have a higher mortality rate because of that. They get sick very, very quickly. They can't mount any additional cortisol response like the rest of the population. There's a lot of different causes that can drive this. I know I said autoimmune's, number one in the US, but we see a lot of other things that can infiltrate the adrenal glands or, hemorrhage, infarct. Often we also see secondary adrenal insufficiency. A lot of folks are getting steroids for other things these days. Chronic opioids can also cause secondary. Um, but I'd say the main things are just, check it. If you're not sure, it really helps to get that on the initial set of admission labs for a hypotensive patient. Cortisol is usually sufficient, but if you get an ACTH level, the endocrinologist in the room will thank you because that really helps us determine, if it's primary, if it's secondary, for what was the driving force of that. And then just to call it, if they are in the critical care setting, cortisol of 20 to 40 can be very normal for these patients if they're making cortisol appropriately. And so treatment, similar to what we have talked about earlier with hydrocortisone, 100 milligrams IV. We usually start that Q8 if we are pretty sure it's, Addisonian, and then we'll taper. They actually don't need the mineralocorticoid on this high dose of hydrocortisone, but if they do have primary, they'll later need Florinef oral. There is some literature, though, on using Florinef in the critical care setting for septic shock. I'm not a critical care attending, so I usually leave that up to them. It's a very low dose, though, in the studies that have come out, that it may actually help lower the risk of all-cause mortality at a dose of zero point zero 0.05 milligrams, which is low. Most of our patients with primary adrenal insufficiency are on, at least zero point 0.1 milligram a day for outpatient. So more to come probably for that research. And then gosh, I do go fast sometimes.
That's
So
right.
we're gonna end on some diabetes management in the critical care setting. I'm inpatient glycemic management medical director, and so do a lot of teaching for folks living with diabetes. So we get asked a lot, what do I do if a patient is on an insulin pump, which I'm not sure how many folks in the patient population there are on pumps, actually. Um, but in general, we usually don't recommend utilizing these in a critically ill patient. So if someone's coming in with severe hyperglycemia, diabetic ketoacidosis or HHS, we're usually taking them off. There are more pumps available now than I could put in one slide. But I try to teach the learners, what to look for. There are actually more that are in Europe that are not, FDA approved in the US as of yet. But there's a lot of what we call patch pumps that are coming out. So they're very, very small, typically hold, 200 units of insulin. And unless you're doing a really thorough skin check on admission, you may miss that a patient is actually still on an insulin pump and receiving insulin by another means. Um, Pumps are typically used in auto mode now, where they are communicating with a continuous glucose monitor. So what do you do with the continuous glucose monitor? This is a picture of a couple of them. Um, and so far, none of these are technically FDA approved for inpatient use in the US, but we don't often take them off if endocrinology is consulted. We do use them for trend data. This last picture are the more common ones that we see, the Dexcom G7 and the Libre 3 Plus. We've actually done a study. This was, gosh, back when I was an endocrine fellow, looking at, well, how reliable are they compared to standard of care? Are they helpful? Are they not helpful? Sadly, we had to end this a little early because of the pandemic, but we did find, and this was done with a blinded sensor at the time to get it through the IRB, but we found that, the sensor is actually picked up on hypoglycemia hours earlier than our morning fasting glucose panel that we were getting for patients who were managed on, basal bolus, multiple injections a day of insulin, or even the IV insulin arm that we had in the ICU. And so, CGM, while it's not, at least in the US, it's not approved for official use inpatient for glycemic monitoring, it can be very helpful to continue just for trend data, for alerting both the patient and nurse to, impending hypoglycemia. We still use the finger sticks as a standard of care, including in the critical care setting. And they may have to remove their device for other things, if they're undergoing an MRI. Not everything is compatible with all imaging, but they're getting smaller and smaller. So it's important to recognize that if your patient is utilizing those technologies when they come in inpatient. Um, Pancreatic emergencies. So there was an update consensus statement in 2024 for what to do, what to look for. Includes some of these as well that we'll get to in terms of, trends, length of stay, mortality. And then I'll briefly touch on the IV algorithm that we use here for IV insulin. So trends for admissions for TKA, these are increasing pretty significantly, and it's not just type 1. We've seen an increase in persons living with type 2 diabetes who are also presenting sometimes at time of onset or time of diagnosis. And diabetic ketoacidosis, it's getting missed in outpatient, or patients aren't presenting when they first start having symptoms of severe hyperglycemia. There's also been an uptrend in euglycemic DKA, with patients living with type 2 being on SGLT2 inhibitors. So if they have enough insulinopenia where they're not making adequate insulin, my threshold is an A1C of 9%. I don't generally start an SGLT2 inhibitor because of that increased risk of them going into diabetic ketoacidosis. So occurrences are going up. And sadly, this is some data that includes US data. It's not this way everywhere. I didn't include in the slide set, but this same article actually looked at the data in the UK, I believe, for their length of stay as well as costs. And so even though length of stay we're getting better at managing these patients, at getting them out of DKA, getting them out of the hospital, cost has been going up significantly, which is a huge problem. What to look at with clinical presentation. So a few things changed with the updated 2024 consensus. guidelines. And some of that is related to the fact that not everybody falls into one bucket of DK or HHS. A third of folks will actually kind of have a hybrid presentation between the two, or have even a mixed acid-base disorder and not just DKA as their primary driver. Um, DKA typically, develops more rapidly. HHS a longer time. The more common scenario we see for HHS are older adults who are found down, have gotten quite dehydrated. Uh, their hyperglycemia shuts down the beta cells essentially, and so they have this relative insulin deficiency, but are less prone to going into DKA because they are still making some endogenous insulin. Um, both sets of patients will have polyuria, polydipsia, weight loss, dehydration. But the DKA folks, because of the acidosis, will have more of the nausea, vomiting, abdominal pain, and then the faster Kussmaul respirations. Diagnostic criteria has changed a bit. We previously had a cutoff of glucose greater than 250 for milligrams per deciliter, and that has been lowered to a threshold of 200. We also have updated guidelines to monitor the beta hydroxybutyrate concentration, both for diagnosis as well as trending for resolution of DKA, to know when to transition them off of the drip instead of only using the anion gap because of the third of patients that will have that mixed acid-base disorder. For HHS, glucose is typically much, much more elevated, greater than 600. Sometimes we see patients coming in the thousands, which is a bit scary that they've gotten that hyperglycemic. These patients, I would say, don't typically have, a marked elevation of the beta hydroxybutyrate, but certainly can have some degree of ketone production from starvation ketosis, but they're not typically acidotic. Um, the thing that, and I'm not sure if this occurs as much where the viewers for this talk are, but in the U.S. we have seen younger patients as well as folks that have insecurities to not only food insecurities but insecurity to getting their insulin or stretching out their insulin due to cost are more frequent flyers and will have more frequent presentations with diabetic ketoacidosis. And the thing I want learners to remember is that, yes, there is increased mortality for patients in general when they present to DKA, but if we look at those who are having recurrent DKA, if they've had more than 5 admissions, their hazard ratio for death is markedly elevated. And I think sometimes we lose sight of that when seeing the frequent flyers. And those are the people we really need to figure out, what's the barrier for you to be able to get your insulin, to be able to, stay in the outpatient land and safely get your medication, because that's a concern. Treatment, there is some overlap in these. Both sets of patients, HHS, DKA, are going to need significant fluids for resuscitation. That will both be treated with IV insulin and will require significant electrolyte repletion, particularly potassium, which that insulin is going to, further lower and sometimes have to be held for potassium repletion. Mortality is also high in both arms, but it's a higher actually in HHS, unless you're a frequent flyer with DKA. And then moving on to, in addition to the IV fluids and IV insulin, we've had a number of protocols that have changed here, actually dating back to, I think, 2022 is when we implemented IV EndoTool as a IV insulin algorithm at our institution, which has been quite helpful in reducing length of stay, reducing the hours that patients are in the critical care setting. Replacement electrolytes are done here, typically off of the BMP every 4 hours. And then, looking into what the cause was. So going back to, gathering more information for what led them to present with DKA. Sometimes it's a silent myocardial infarction. Sometimes it's an infection that went overlooked. Sometimes it is simply, that insulin insecurity, and they had stretched things out or missed a few doses, of a long-acting insulin if they're living with type 1. And then resolution criteria was also updated in 2024. And so for transitioning off of the IV insulin drip, we like glucose to be stable, ideally under 200. They should have resolved their acidosis, pH above 7.3, and then the beta hydroxybutyrate, if you're able to trend it, less than 0.6, which we still have some issues at different hospitals with not being able to trend that one in real time. It depends everywhere, it seems, across even the US. And then this is just an example of what EndoTool does. There's a number of different software IV insulin algorithms. Glucomander's one, EndoTool. Um, so it has a DKA mode of therapy that starts initially to get folks more rapidly down closer to the 200 or so range. And then after that, it has a hyperglycemia protocol for more of a soft landing. And so for our MICU, our target is 120 to 160 to try to land in that area. There's a number of data points that the algorithm is utilizing. In addition to their glucose level, it's also inputting the type of diabetes they have in terms of insulin resistance, type 1 or type 2 or unknown, age, gender, weight, kidney function, electrolytes, if they've received steroids at all and need to factor in, more insulin resistance. Can also actually utilize carb intake, which we don't really recommend folks eat while they're on the drip. But if for some reason a patient needs to, you technically can put in the carb that they ate, and the IV insulin algorithm will actually utilize that as well to adjust their dose. So we recommend these folks are NPO while they're on IV insulin. And then you can utilize their hourly rate, on the drip over 4 hours, preferred, multiply that to get their 24-hour total daily basal. And then we usually round down a bit and give 80% of that. If your IV drip doesn't make sense or, they're fluctuating significantly, you can always use their, calculated total daily dose. So for someone who has type 1 or they're insulin naive and they're lean, you would use this, zero point 0.2 to zero point 0.5 units per kilogram per day to get their total daily dose of insulin, and then take half of that to administer as their long-acting insulin, and then plan for the other half to be their mealtime and correction. And then similar for if they're living with type 2 diabetes or have, obesity, have signs of insulin resistance, acanthosis nigricans, for example, you would use a higher weight-based amount to start. So 0.5 to 1 unit per kilogram per day. And then similarly, split that total daily dose of insulin into roughly half of that being their long-acting insulin, and then half of that being their, mealtime correction insulin. At my institution, we usually give the long-acting basal insulin about 2 hours before stopping the drip, and also want to make sure that the patient is feeling well enough to actually be able to eat. So if someone is declared, they're still, maybe their anion gap has closed, but their beta hydroxybutaраtes are still high and they're not looking great. They're still throwing up. That's a patient we would continue on the drip until they're feeling a bit better, and then give the long acting once they feel well enough to eat, and then stop the insulin drip about 2 hours after that. And then particularly for those who have type 1, making sure that, there are orders in for covering their food intake for when they start eating so that they don't, revert back to marked hyperglycememia. All right. And with that, I know I went a little fast. I never am sure with the timing and a little bit of a delayed start, but these are my references. I know we highlighted at the beginning, but was going to call out again that we have this new diabetes fellowship that we're very excited about, as a one-year fellowship opportunity for folks to support those living with diabetes. It's not for full endocrine fellowship. It's specifically to be a diabetologist and support those with, insulin regimens, continuous glucose monitors, insulin pumps. And then it's open for folks who have graduated for internal medicine, med peds, or family medicine. And then if folks are viewing in real time, or if they're viewing later, it would be super helpful to me, and I would appreciate getting any feedback. I have a QR code just to send in a quick survey for, what you thought of the talk, if you liked it, if there's any feedback for things that I could change or make better for future iterations of trying to cram all of endocrine emergencies from the top down, for those who may be in a critical care setting or, have patients that would benefit from this education.
All
But thank you
right.
again for having me.
Yeah, it was great. Great. Amir,
Thank
any
you.
questions? Any questions, Amir?
No, it was very clear. Thank you very much.
Let me ask you a couple
Thank
of
you.
questions. Let
Yeah,
me ask you
sure.
a couple. So, I always wondered why HHS has that much higher mortality rather than DKA. Is it because it's triggered by some other bad thing and the mortality is really related to the underlying problem versus the
Yeah, so I think
HHS per se?
I mean, from what I've seen clinically, I think that is definitely part of it. The DKA patients, sometimes I mean, there is an underlying, but often from what I see lately, it's lack of insulin. So there's not always an inciting event. For the HHS patients, there typically is. Something had them so altered that they were often found down or
Mm,
had some type of an infection that they did not seek out care for, or had a heart attack that they didn't seek out care for and just got markedly hyperglycemic. Um, and I think also just the degree of how hypovolemic they are. I mean, they can be, 10 liters down in fluid. And so every organ in the body is not functioning at a great
right.
capacity by the time they make it into the hospital. Um, so I think they have just, yeah, they're several days behind usually in terms of what their body needed. And that's also a group of patients that are typically older. And so they have less reserve to recover from that type of an acute insult.
Right. No, no, I get it. I get it. One other question is AI, right? I mean, AI obviously has the potential to do lots of things in
Oh,
medicine,
yeah.
right?
So
What?
many.
Yeah. How do you say AI helping in managing these complex patients who present with I don't know, DKA or HHS in terms of
Mm.
predicting um, events and trying to
Yeah, I think it's
help the
really
treatment?
interesting. So I mean technically the IV insulin algorithms that I was describing, that's essentially a form of artificial intelligence for how it
Mm.
is changing their insulin dosing in a smarter and faster way than having the endocrine consult person there, adjusting their insulin rate every 30 minutes, every hour. That's essentially what that tool is doing with, over 10 inputs. So in some ways, in some hospital systems, we're already using AI to get to normal glycemic state faster and safer. We see a lot less hypoglycemia, a shorter length of stay, shorter time of requiring IV insulin than with our prior paper-driven algorithms that we were using. But I think in terms of other uses of AI, which I think is more what you're asking, open evidence is one that I see utilized a lot here that will, there's so many different flavors of artificial intelligence and knowing what it's pulling for sources, knowing if it's hallucinating, being able to go back and double check, I think is still going to be important. Um, I have a separate talk actually that I give on EHR optimization that I gave at a national conference this past year for ACE, which is a big endocrinology group. And I think it's very interesting. I use AI every day, primarily in the outpatient setting. So I have an AI scribe that I've used now for over 2 years,
Mm.
which has helped me tremendously with my charting burden of documentation. Um, but it does sometimes glitch. If there's someone else in the room and they say that they had a heart attack and they were in the hospital recently, it'll pull that in and you have to go back and edit it. So it's not perfect, but it definitely helps. I'm trying to remember who I would be quoting. Gosh, there's a recent book, and I'm blanking at the moment on his name, called Deep Medicine. I think it was Dr. Topol. He's a cardiologist
Sure.
who, I think he's the one who was, given credit for this. That you know, basically doctors who are not there aren't going to be doctors in the future who are not using AI. The ones who are using AI will essentially replace the ones who are just not embracing this as a wave of the future. Um, but I still think you have to be careful with it. I mean, there's a number of them that you can use. I tend to use either the Doximity Ask feature, if I'm having to generate a prior auth to an insurance company who won't cover a medicine that is 1,000%, approved, should be approved, should be indicated, but I can't get insurance to cover it. You do have to be careful with what you're putting in. These are not necessarily HIPAA protected. And so putting in patient-specific information, I do think is a concern. But if you're using one, I tend to prefer open evidence if I'm having to actually look up, what are there changes in guidelines for this? Has there been any updated literature on how I should best approach, this rare endocrine or whatever, whatever diagnosis you're looking into. Sometimes that's faster than me going to PubMed and trying to find, a recent article or recent guideline. You can ask it very specific questions and it will give you the links. And I feel like it hallucinates less than some of the other tools, like if you're using, Chat GPT or Claude, or I don't know
Right.
what other
Right.
ones would be used where
Right.
you are, but I do think it's fascinating.
Right. And I just wonder with one last question in terms of using the EHR to sort of trigger protocols earlier, right? Obviously with
Mhm,
sepsis, right? The
mhm.
EHR now, I would say, I don't know, commonly, very commonly, maybe universally, right? You can identify the patient at least at risk of sepsis, a tachycardia, a
Yes.
tachypnea, a high white
Yeah.
count, and the EHR flags that, and then basically, I don't know, tells the provider, tells the nurse, this patient may
Yeah,
have sepsis, so
correct.
take the blood cultures, start the antibiotics, get somebody to call for the ICU, draw a lactate, etc. Is there
Yeah.
anything similar for these sort of diabetic emergencies or other endocrine emergencies
Oh,
where
sure.
if
So, not
you
that I know
yeah.
of. We actually tried to pilot something like that, and it sadly it did not pick up. We have something similar to what you're describing for, general sepsis. We have an early warning score system
Hmm.
that, gosh, it rolled out, I think, my intern years, like 2013, 2014. And I can't recall everything that it pulls in. I mean, I know certainly the vitals are a big driver for that protocol. I can't recall if it actually pulls in the white blood cell count to trigger this, alert of, hey, your patient's probably not doing so great. You should probably go lay eyes on them and see, if other things are indicated, such as, the cultures and checking the lactate, et cetera. Um, we have tried having a protocol for looking at anion gap to essentially flag adding on a beta hydroxybutyrate to
Hmm.
patients automatically who are living with diabetes. And sadly, it didn't go very far. We had a hard time getting on the same playing field with our nephrology colleagues for what degree of acidosis they were comfortable having that flag in terms of a population health standpoint. You don't want it to flag on too many because that puts a burden on the lab to run all these beta hydroxybutyrates to then get, a number of false negatives because maybe they were acidotic from something else. So we tried doing that as a quality improvement project here, but it ended up, yeah, did not survive.
Got it. Got it.
Yeah.
Very interesting. All right. Well, Amir, it
Yeah,
was
great
great, no?
questions.
Thank you very,
I
very
think in the
much.
future we probably will have something to that
Right. I mean,
degree.
it
I
would,
mean,
it would,
I'm sure
yeah,
in my career, I will log in and my patient list for consults might be generated by the EHR telling me who I need to go see because it says that they're probably in DKA.
right. Of
That
course.
won't surprise me.
Right. Right. All right. Fascinating. Well, yeah, one very, very last question. You talk about your
Yeah, sure.
fellowship. You talk about the fellowship. Is it open to international
Oh, that's
graduating
a good
residents
question.
such as from Israel?
Yeah, I am not 100% sure. Dr. Brooke Baggett would be the person that I should ask. Yeah, she's going to be the fellowship director for that.
Right. So let me know
I'll have to
because
check
if,
in.
for instance, there is the possibility that you could accept academically appropriate
Hmm.
candidates from outside the United States slash Canada,
Yeah,
we'll put the word around and maybe, somebody from Israel will be interested.
yeah, I will find out. It's new,
Excellent.
so I don't know have all the answers for that.
Right, but
I would be one of the
it,
instructors for folks doing that fellowship though. So I'm very
right,
excited about it. We need more people that are passionate about helping those with diabetes.
right. Well, look, ask and let me know what the answer is.
Yeah, we'll do.
Great. Well, this was
Well, thank you
fantastic.
so much for
I'm
having
sorry
me.
about the fact that it's just the two of us, but
Oh,
at
that's
least
okay.
I'm sure Amir will agree with me. It was really interesting, and
Yeah,
Yes.
we will load it up on the YouTube channel. So it'll still get
sounds good.
some airing somehow
Yeah.
asynchronously.
Well, I hope y'all have a good rest of your day. I'm gonna go back to
Very
getting
good.
my day started.
Okay.
I
All
know.
right. Thanks
Have a
again,
Thank
good
you.
one.
Katie. And Amir, thank you for showing up.
Uh,
Thank you.
All right, guys. Bye bye now.
bye. Take
Bye.
care.
Bye.